Welcome back to NurseSpeak English. I'm Maya. In episode 1, Rosa gave her first shift handoff. In episode 2, she called a physician about a deteriorating patient at 2 in the morning, and she did it with clarity and courage. Today, Rosa faces something that many nurses find even harder than a doctor's call: a family meeting. A patient's condition is not improving. The family has questions. They are frightened. They are grieving. And Rosa must communicate with them honestly, compassionately, and professionally in English. Today's 5 phrases: Prognosis, Palliative Care, Advanced Directive, Therapeutic Communication, and Actively Dying. This episode is not easy, but neither is nursing. Let's begin. Before we go in, how are you feeling?
Honestly, nervous. Mr. Foster's wife, Mrs. Foster, she has been crying since this morning, and their daughter flew in from Texas last night. They have so many questions, and I don't always know how much to say, where the line is.
That's a really important thing to be aware of, the line between what a nurse communicates and what a physician communicates. Do you want to talk through that before we sit down?
Yes, please.
Okay. As nurses, we do not deliver a diagnosis. We do not give a prognosis, meaning we do not tell a family, your father has 6 months to live, or he is not going to recover. That is the physician's role. What we do is we support, we clarify, we listen, we translate medical language into human language. We sit with the family when the doctor has left the room and they are still in shock and they need someone to hold the space with them. That is our role in a family meeting. Does that make sense?
Yes, so I don't say what will happen, but I can explain what is happening right now.
Exactly. And you can answer questions within your scope. If they ask, "Is my father going to die?" you don't answer yes or no. You say something like, "That's such an important question, and I want to make sure Dr. Patel answers it fully. What I can tell you is that your father is very sick, and we are doing everything we can to keep him comfortable and supported." Then you get the doctor, okay?
Okay, I can do that.
You can. Let's go in. Good morning, Mrs. Foster. I'm Maya, one of the ICU nurses caring for your husband, and you've already met Rosa. She was with Gerald all through the night.
Yes, she's been wonderful. This is our daughter, Christine.
Good morning, Christine. I'm so glad you were able to come.
Thank you. We need to understand what is happening. The doctor came this morning and explained things, but it was very fast, and we had so many questions after he left, and we didn't know who to ask.
That is exactly why we're here. We have time, there is no rush. Ask us anything you can, and if it's a question we need Dr. Patel to answer, we'll make sure that happens before you leave today.
He said something about palliative care, and I looked it up on my phone, and it said it was for people who are dying. Is Gerald dying?
Let's pause here, because this moment, this exact question, is one of the hardest a nurse will ever face. And it's also a moment to explain an incredibly important and commonly misunderstood term: palliative care. Many people, when they hear palliative care, believe it means a person is at the end of their life and treatment has been given up. That is a misconception. Palliative care is a specialized type of care focused on providing relief from pain, symptoms, and the emotional stress of a serious illness at any stage of that illness. A patient can receive palliative care while also receiving aggressive, curative treatment. Palliative care is not about giving up. It is about quality of life alongside medical treatment. It includes pain management, emotional support, spiritual care, and helping patients and families make informed decisions. Now, watch how Maya handles this moment with Mrs. Foster. I want to make sure you have the most accurate understanding of what palliative care means, because I think the definition you found online may have frightened you more than necessary. Palliative care does not mean we have stopped trying to help Gerald. It means we are bringing in a specialized team whose entire focus is making sure he is comfortable, that his pain is managed, that he is not suffering, and that your family has support too. The palliative care team works alongside his heart failure team. They are not replacing anyone. They are adding another layer of care.
So they haven't given up on him?
No, Gerald is still receiving active treatment. The Lasix we gave him last night is working. He produced over 800 milliliters of urine in the first 4 hours, which is a good response. His breathing is somewhat easier this morning than it was at 2 a.m. We are watching him very closely.
But what is his prognosis? The doctor used that word, prognosis. What does that actually mean in plain English?
Prognosis means the expected course or outcome of a disease. It is the medical team's best understanding of how a condition is likely to progress, whether a patient is expected to improve, remain stable, or decline over time.
And what is my father's prognosis?
That is a question I want to make absolutely sure Dr. Patel answers for you directly, because he has the full clinical picture, and I want you to have the most accurate and complete answer possible. What I can tell you is that your father's heart failure is serious. It is at an advanced stage, and the team is working to stabilize him. I will personally make sure Dr. Patel comes back to speak with you before the end of this morning. I will not let you leave without that conversation.
Thank you. I appreciate that.
Can I ask, did your father ever fill out any documents about his wishes, about what kind of care he would want if he became very ill?
He has a living will. We made them together about 3 years ago when his heart started getting worse. The lawyer helped us.
That is so important, and I'm really glad he did that. A living will is one type of what we call an advance directive. Rosa, can you explain that term?
Of course. An advance directive is a legal document in which a person states their wishes for medical care in advance, meaning before a crisis happens, while they still have the ability to make decisions clearly. It allows a person to say things like, I do not want to be kept alive on a breathing machine if there is no hope of recovery, or I want all possible treatments attempted regardless. It also often designates a healthcare proxy, which is the person legally authorized to make medical decisions if the patient cannot speak for themselves.
That's me. I am his healthcare proxy.
Yes, and that is an enormous responsibility, and we want to support you in it. If you have a copy of that document, it would be very helpful to have it scanned into his chart so that every member of the care team, every doctor, every nurse, every specialist can see his wishes clearly documented.
I have it in my bag. I brought it this morning because something told me to.
Something told you, right? Can we make a copy before you leave today?
Yes, of course.
Can we see him? We've been waiting out here for an hour because they said he was being assessed.
Yes, he is resting right now and his vitals are stable. I want to prepare you. He has more lines and tubes than he did yesterday. He has a urinary catheter now, so we can measure his urine output precisely. He still has the oxygen mask. He may look more unwell than you expect, even though his numbers are slightly better this morning. I want you to know that before you walk in, so it doesn't frighten you.
Thank you for warning us.
Rosa will take you to him in just a moment. Before you go, I want to check in with both of you, not about Gerald's medical status, about you. How are you doing? Are you eating, sleeping?
Not really. No.
That's what I thought. The palliative care team has a social worker and a chaplain who meet with families, not just patients. If you would like someone to talk to, someone who is not a doctor, not making decisions, just listening, I can arrange that today. No pressure, just an option.
I think I might need that.
Then I'll make it happen.
The charge nurse mentioned this morning that Mr. Foster may be, she used the phrase, actively dying. I've seen this in charts before, but I want to understand exactly what it means clinically.
It's an important term, and I'm glad you asked. Actively dying refers to the final phase of the dying process, typically the last hours to days of a person's life. There are clinical signs we look for: mottling of the skin, a bluish, blotchy discoloration, usually starting in the feet and knees, changes in breathing, periods of apnea, or a pattern called Cheyne-Stokes breathing, where breathing becomes irregular and shallow with pauses, decreased urine output, sometimes none at all, cooling of the extremities, decreased consciousness and responsiveness, changes in the sound of breathing, sometimes called the death rattle, which is the sound of secretions in the throat that the patient can no longer clear. These signs do not mean we have failed the patient. They mean the body is completing its natural process. Our role shifts from curing to comforting, from treating to being present.
Is Mr. Foster actively dying?
Not yet, but he is very ill, and the team believes he may be approaching that phase in the coming days if he does not respond to treatment. That is why today's conversations, the advanced directive, the code status, the palliative care referral, all of it matters so much right now. We are trying to honor who he is and what he wants before he is no longer able to tell us.
I understand. Ready?
Ready. Oh, Gerald.
Helen, you're here. Christine, sweetheart.
Hi, Dad. We're here. We're right here.
I'll give you some privacy. I'm just outside if you need anything at all. You okay?
How do you do this every day, Maya? How do you walk in and out of rooms like that and not fall apart?
Who says I don't fall apart? I have cried in this hallway more times than I can count. In the supply closet, in my car before I could drive home. Feeling things does not make you a weak nurse, Rosa. It makes you a human one. The day it stops affecting you, that is when you should worry.
In the Philippines, we are taught to be strong for the family, not to show emotion.
I understand that, and there is wisdom in it. The family needs to feel that we are steady. But there is a difference between being steady for your patient and being made of stone. You can hold your composure at the bedside and still feel everything. In fact, what you feel is information. It tells you what this family needs. It makes you more attuned, not less professional. We call it therapeutic communication, the intentional use of words, tone, body language, and silence to create a healing connection with a patient or family. It is one of the most advanced skills in nursing, and you used it naturally in that room today without even knowing it. I did? You warned them about the lines and tubes before they walked in. You told them you would personally make sure the doctor came. You stepped back and gave them privacy at exactly the right moment. You didn't fill the silence with noise. That is therapeutic communication. That is skill.
I just did what felt right.
That's what skill looks like when it becomes instinct.